Today we'll talk about a very important subject in the field of linear endoscopic ultrasound, which is linear EUS examination of the mediastinum. My agenda today will include introduction, applied anatomy of the mediastinum, identification of lymph nodes stations according to the International Association of Lung Cancer Classification, linear EUS examination techniques of the normal mediastinum, and finally the conclusion. Approximately 40% of all nodes thought to be malignant by CT criteria are finally proved to be benign, and about 20% of nodes deemed to be benign by CT criteria are finally proved to be malignant. So CT has limited overall diagnostic accuracy, less than 75% for differentiating benign from malignant lymph nodes. Also, PET-CT positive lymph nodes may not be malignant in up to 50% of cases. Combined imaging and sampling by EUS FNA or endobronchial ultrasound FNA are the techniques of choice in case of mediastinal nodal sampling, which is the mainstay for evaluation of lung cancer. It is a minimally invasive technique with a very good safety profile. The mediastinum contains many structures: the trachea, part of the main bronchi, the esophagus, and the venous confluence of the left brachiocephalic and right brachiocephalic to form the superior vena cava, the arch of the aorta and the descending thoracic aorta, the pulmonary artery and its right and left branches, the left atrium, and the diaphragm. Examination of the mediastinum has 6 levels. Level 1 is above the thoracic inlet. Level 2 is above the aortic arch. Level 3 is at the aortic arch, about 22 cm from the dental arch. Level 4 is at the level of the pulmonary trunk and right pulmonary artery. Level 5 is at the level of the left atrium, about 33 cm from the aortic arch, and below the diaphragm for liver, adrenal gland, and celiac lymph nodes. According to the International Association of Lung Cancer Classification, there is a total of lymph node stations numbered from 1 to 14. Stations from 2 to 9 are central stations, so they are very well seen by endoscopic ultrasound, except station 2R. Station 10, right and left, are located at the hilum of the lung, so they can be seen by endoscopic ultrasound also, but with some manipulations, as we will see later. While stations from 11 to 14 to the right and to the left cannot be seen by endoscopic ultrasound because they are peripheral stations and they are seen only by endobronchial ultrasound. So this is the station seen by EUS or EBOS. EUS, as I told you before, can see stations from 2 to 9, and with some manipulation we can see station 10, right and left, while stations 11 and 14 can be seen only by endobronchial ultrasound. Endobronchial ultrasound cannot see stations 8 or 9 because they are below the trachea. So both are complementary in visualization of all stations of lymph nodes, which is very important for staging of lung cancer. So there are many levels, 6 levels, and many stations, about 14 stations to the right and to the left. So there should be a roadmap for systematic visualization of this station by endoscopic ultrasound, and there should be landmarks to search for and visualize these different stations. We suggested a rather simplified way for linear EUS examination of the mediastinum in our review published in endoscopic ultrasound last year. We can start the examination of the mediastinum from below upwards, or from above downwards, or going up and down several times. All methods are correct, and the best method is the method that you are used to do and the method you are perfecting. Here my suggested way of examination is to start from below upward. From below, to start localization of the intrahepatic portion of the IVC just below the cardiac. Here this is the liver and this is the intrahepatic portion of IVC. We will withdraw the echo endoscope above to follow the IVC into the right atrium. And here there is a small valve between the IVC and the right atrium, which is the Eustachian valve. So this is the IVC, right atrium Eustachian valve, and here this is segment station 9. Station 9 at the pulmonary ligament, which is located at the insertion of IVC into the right atrium. So this is station 9. So this is station 9, and here this is a small lymph node at station 9. We keep withdrawing the echo endoscope up slowly with slight counterclockwise rotation. Here this is the IVC and the right atrium and station 9. We'll keep withdrawing the echo endoscope up. We can see most of the cardiac chambers. Here this is the right atrium and this is the left atrium, and this is the aortic valve, and this is the root of the aorta. This is the aortic valve, and this is the left atrium, and this is the more counterclockwise, and this is the left ventricle, and this is the mitral valve. We keep withdrawing up to see the pulmonary trunk, and the pulmonary trunk will give rise to the right pulmonary artery. So this is the left atrium, root of the aorta, and this is the right pulmonary artery. The area in between the left atrium and the right pulmonary artery is station 7 at the subcarinal area, 25 to 32 centimeters from the incisor. This is a very important station, station 7 at the subcarinal area, because it is a very common lymph node station for lymph node metastasis from different tumors, not only the lung cancer but also gastric carcinoma, breast cancer, and even pancreatic cancer. So here station 7 subcarinal area is very important, and it is located between the left atrium and the right pulmonary artery. Yes, this is the subcarinal area. This is the right pulmonary and left atrium, and this is the left ventricle, aortic valve, descending aorta, and the pulmonary trunk. Then let us look for station 10R. 10 right. Here from the subcarinal area, we just do a very gentle clockwise rotation. When we do clockwise rotation, you can see the superior vena cava, right atrium, and inferior vena cava. And the station 10R is at the level of the superior vena cava. Then let us see. This is the subcarinal area. We are still now in the subcarinal area. We will do slight clockwise rotation. This is the right pulmonary artery, left atrium. Here this is the superior vena cava, inferior vena cava, and the right atrium. Here this is station 10R. So we can see it, but by some manipulations. So this is the superior vena cava, inferior vena cava going to the right atrium, and this is the subcarinal area, area 7, between the right pulmonary artery and the left atrium, and here this is the station 10R in relation to the superior vena cava. At this level, we do clockwise rotation by 180 degree to go from station 7 subcarinal to station 8 around the descending thoracic aorta. So we'll do 100 degree clockwise rotation. Yes, this is the descending thoracic aorta, and here this is station 8. Very nicely seen and very easy to locate. Yes, this is station 8. We will go back to the subcarinal area, station 7, and by then we want to go the aortopulmonary window, which is a very important area because it is also a common site for metastasis. From the subcarinal area, we will do 3 movements. Slow upward withdrawal of the echo endoscope, and the counterclockwise rotation and upward deflection by the big wheel. Yes, very nice. Here we can see the aortopulmonary window or Mickey Mouse appearance. This is the big ear of Mickey Mouse, and this is the other big ear. Here in between the 2 ears of Mickey Mouse, we can see station 4L in between the echo endoscope and the left pulmonary and the aortic arch. Mickey Mouse appearance and station 4L is between the echo endoscope, and here this is the aortic arch, and here this is the left pulmonary artery. So station 7 is between the left atrium and the right pulmonary, and station 4L aortopulmonary window is between the left pulmonary and the aortic arch. Here station 4L and station 5 is away in between these both structures and away from the echo endoscope, and station 6 is behind the aortic arch, and the station 10 left is deep to the left pulmonary artery. So this is again the aortopulmonary window formed by the aortic arch and the left pulmonary, and here 4L in between these 2 structures and echo endoscope, and station 5 is deeper, and station 6 is behind the aortic arch, and the station 10L is behind the left pulmonary artery. This is a very important station, which is the aortopulmonary window or the Mickey Mouse appearance. Okay. Yes, here very nicely seen in the schematic presentation. Then we will keep withdrawing the echo endoscope up to see a large branch of the aortic arch, which is the left subclavian artery. At the level of the left subclavian artery, we can see station 2L. Station 2L. This is the left subclavian artery, and here this station 2L. At that level, when we do clockwise rotation, we can see the carotid artery, the left common carotid artery, and the venous confluence of the left internal jugular to combine with the left subclavian to form the left brachiocephalic. Here this is station 3A, 3 anterior. 3 posterior we cannot see by the echo, by the EUS, but we can see station 3A at the level of the venous confluence of the left internal jugular vein at its union with the left subclavian vein to form the left brachiocephalic or left innominate vein. Yes, this is station 3A. Station 1 is in the neck. We keep withdrawing the echo endoscope to see the left thyroid lobe and the left internal carotid artery, and here this is station 1 at the neck. Here this is a simple short video to see all stations again. With this is the inferior vena cava again to repeat, and here this is the station. This is second valve with inferior vena cava and right atrium, and here this is station 9. We will keep withdrawing up with counterclockwise rotation. Tamam. Okay, with counterclockwise rotation. This is the right atrium, and here will come the left atrium. Yes. Here we withdraw the echo endoscope, and this is the aortic root and the aortic valve, and this is the left atrium, and this is the left ventricle and the mitral valve. We will keep withdrawing with counterclockwise rotation. We will see the pulmonary trunk, which will give rise to the right pulmonary artery, and here this is the subcarinal area between the right pulmonary artery and the left atrium, station 7. Okay, and this is a schematic picture. Slight clockwise rotation, we can see the superior vena cava, right atrium and inferior vena cava, and here station 10 right, 10R, at the level of the subcarinal area. From here we will do 180 degree clockwise rotation to go to the descending thoracic aorta and station 8. This is the descending thoracic aorta here and slightly downwards. So this is station 8. So we saw now station 9, 7, 10R, then 8. We will go back by 180 degree counterclockwise to the subcarinal area, and here we do 3 important movements: withdrawal of the echo endoscope, slight counterclockwise, and upward deflection of the big wheel to see the aortopulmonary area or Mickey Mouse appearance. Here you can see 4L, 5, and station 6 deeper to the aortic arch, and station 10L deeper to the left pulmonary artery. Okay, we will keep withdrawing the echo endoscope to see the important branch of the aortic arch, which is the left subclavian artery, and here this is station 2L. Yes, 2L at the level of the subclavian artery, and we will do clockwise rotation to see the common carotid artery and the venous confluence of left internal jugular, left subclavian, and left innominate, and here station 3 anterior, 3A. Okay, yes, very nicely seen, and we will keep withdrawing to see the thyroid gland and station E in the neck of the patient. This is another nice video showing extensive lymphadenopathy almost always involving all mediastinal station. Here it is the IVC left atrium and station 9. Yes, here is station 9, and we see that there is a lymph node at station 9. Yes, this is a lymph node at station 9 at the pulmonary ligament. And here this is subcarinal, station 7. We see that multiple large lymph nodes. This is the left atrium and the right pulmonary artery. Left atrium, right pulmonary artery, and the subclavian area. There are many lymph nodes, very large lymph node and multiple variable size lymph nodes. And here we will do clockwise rotation 100 degree, 90 degree we can find the azygos vein, and more 90 degree clockwise we can see the descending aorta and the multiple lymph nodes as the descending aorta at station 8. So we have lymph nodes at station 9, 7 subcarinal, and 8. Then we go back to station 7 and we keep withdrawing the echo endoscope with counterclockwise rotation and upward deflection of the big wheel to see the aortopulmonary window, aortic arch and left pulmonary artery. This station 4L, there is a lymph node, and station 10L and station 5 and station 6 behind the aortic arch. So there are, we keep withdrawing the echo endoscope, and this is the left subclavian artery, and here these are multiple lymph nodes. Yes, this is multiple lymph nodes. In station 2L and station 3A. So there are multiple lymphadenopathy affecting nearly all stations of the mediastinum. So my take-home messages: EUS examination of the mediastinum is important, especially in end staging of malignant masses. EUS is very important in tissue acquisition of mediastinal masses and lymph nodes. During EUS examination of the mediastinum, you can start from above downwards or below upwards, but try to identify the landmarks of each anatomical region. Thanks to my dear colleague Dr. Ahmed Al-Zamzami and my dear colleague Dr. Katarzyna Pawlak from Poland for sharing me our journey towards linear EUS examination of the mediastinum. And thanks for your attention.